Good evening, ladies and gentlemen. Welcome you all to this webinar on ECG Basic and Beyond. This is the 11th lecture of this series, and as usual, we have got our course directors, Professor M. Atahar and Professor Abdul Wadud Chowdhury with us. We have got three foreign faculties with us, Professor Dr. Rafiq Ahmed, Professor Ahsan, and Professor Orun Maske, and number of professors and teachers in our panelists, including Professor Mahbubur Rahman, Professor M.G. Azam, and Professor Mohsin Hossain. Our today's lecture will be delivered by Dr. Mohammad Khalequzzaman, who is the Associate Professor of Cardiology, Dhaka Medical College. But before that, may I request Professor Abdul Wadud Chowdhury, sir, to say a few words about today's session and about our faculties. Abdul Wadud Chowdhury, sir, please.
Assalamu alaikum and good evening, everybody. Today our session is about the ECG changes in different metabolic disorders and electrolyte disturbances, which is commonly found in different situations, both in hospital and out hospital, in our chambers as well as in critical care setting. Now today we are going to hear the lecture from Dr. Khalequzzaman. He is associate professor in my institute and I'm a fan of his. You will find out why. I won't elaborate on it. He is very elaborate, deceptively simple, but he is very knowledgeable and thorough person. You will be amazed about his depth of knowledge. Today we are lucky enough that we have Rafiq sir is our mentor. He is always with us, and he is a USA-based epicardiologist, but to us, he is the founder of electrophysiology service of this country. And also we have Professor Chowdhury Hafiz Ahsan. He is the top of his class in Dhaka Medical College. He is a bright star. We have grown up when we were students, listening to their reputation and wanting to be like them. At present, he is Cardiology Fellowship Director and Head of Department, University Medical Center, Las Vegas, Nevada. And also, he is currently Governor of American College of Cardiology, Nevada chapter. And recently he has published a book for the COVID-19 frontline doctors named COVID-19 Companion Handbook, a case-based approach. It's a very nice book. You'll be amazed about the diversity of the cases that has been presented in that book. We have also my friend Professor Orun Maske from Nepal, and from the country we have cardiologists, internal medicine specialists, critical care specialists, and sometimes I think Professor Khulur Rahman, he doesn't show up, but he is chief of anesthesiology in National Heart Foundation. Join us. We are lucky enough to have all of them here. Without much ado, now I am asking Professor Khalequzzaman to start his lecture.
May I go to slide share?
Yes, you can go, sir.
Before going my lecture, starting the lecture, I must wants to express my gratitude for a great introduction from the part of the Professor Abdul Wadud Chowdhury. Very good night and Assalamu alaikum to everybody who are joining here. The course director, Professor M. Atahar Ali, Professor Abdul Wadud Chowdhury, Dr. Rafiq Ahmed sir, and Chowdhury Frizul Hassan from USA, and other foreign guests and the panelists, and the panelists from countries as well. It is my great pleasure as well as a great endeavor. You may think about that I'm going to present my today's presentation or speech in front of those cardiologists and the electrophysiologists like Dr. Rafiq Ahmed, Chowdhury Hafizul Hassan, Atahar Ali, and Professor Abdul Wadud Chowdhury. So let us start our talk about the ECG in electrolytes and metabolic disorders. And Professor Atahar sir lastly told that may I add something about thermal changes in ECG and also the ECG in pulmonary disorders if we get enough time after the discussion of the electrolyte disorders. So before going to discussion, what is an electrolytes? Electrolytes are the minerals found in the body fluid that carry an electrical charge and are essential in keeping the heart, nerves, and the muscle functioning properly. As such, it is important to maintain a precise and a constant balance of the electrolytes for its proper functioning. So what are the function of the electrolytes? Maintain the fluid osmolality. It is concerned mainly with the resting membrane potential and the action potential, which is very much essential for cardiac activity to go with normally. And concerned with neuromuscular excitability and the tissue function. Some specific function of certain electrolytes are there, like calcium is responsible for coagulation and the bone mineralization, buffering activity offered by the bicarbonate and the phosphate, and is cofactor of certain enzymes like magnesium, calcium, zinc. These are acting as a cofactor, although these are not participating directly in the membrane potential, but through indirectly by modulating the functions of different coenzymes and the cofactors, they are participating in maintaining the membrane potential. So in terms of the electrolytes which are very much vital for the heart are potassium, calcium, and magnesium. And these electrolyte imbalances can produce the cardiac arrhythmias. ECG is a tool which can detect as well as estimate the severity of the electrolyte imbalances and can judge whether there is any risk of serious arrhythmia or not. And there is a correlation sometimes or sometimes may not have correlation between the severity of the electrolyte imbalances and the visible ECG changes. So going into details about the electrolyte disorders producing ECG changes, we have to recapitulate our knowledge about the action potential of the cardiac muscle cells, particularly for the students here. We have 5 phases of the cardiac action potential in cardiac muscle cells, and conducting system in the sinus node, it is not as like as these muscle cells. And you see the depolarization, which is mainly responsible for the sudden inrush of the sodium into the cell, followed by early repolarization, that is for opening of the I2 channel for potassium to go out, and the plateau phase is maintaining the calcium mainly. At the same time, there is efflux of the potassium out of the cell to the extracellular fluid during phase 3 phase. And the phase 4 is maintaining predominantly by the potassium. And next, you can see the action potential of the SL node. It differs substantially from the action potential of the muscle of the atrial as well as ventricular muscles, that it lacks the phase 1, phase 2 as well as phase 4 of the action potential. Phase 0 correlates with the QRS complex with the action potential. Phase 1, the repolarization. Phase 2, 3 are the repolarization wave. This is repolarization. Sorry to this will be phase 2 will be repolarization as well. Phase 1 corresponds to the J point, and the phase 2 ST segment. Phase 3 is T wave, corresponds to the T wave. And the phase 4 is the resting membrane potential, which corresponds to the TQ segments of the electrocardiogram. So by influencing the action potential of the cardiac muscle cells, pacemaker cells, and the conducting system of the heart, electrolyte can produce disorder or abnormalities in the rhythm, many a times, P wave in a good number of cases, PR interval, QRS complex, ST segments, QT interval, T wave, and U wave, either singly or in combination. The electrolyte imbalances may produce some impact on these wave intervals and the segments of the ECG. So let us go first in the potassium, because potassium is a vital elements the electrolytes which are maintaining whole of the part of the repolarization phase, including the resting membrane potential. So you see the fruits are very much rich in potassium, including the yogurt and the other fruits, fishes, as well as potatoes. The normal range of potassium in our body is in adult 3.5 to 5 milliequivalent per liter, and we call it hyperkalemia when the level exceeds greater than 5 milliequivalent per liter, or somewhere it is written 5.5 milliequivalent per liter. And depending on the level, it can be graded as mild, moderate, and severe. We call it severe when it exceeds 7 milliequivalent per liter. Before going into the ECG changes in hyperkalemia, let us have a case scenario. An 18 years old female having diabetes, hypertension, CKD. She was on dialysis and he missed dialysis on 2 occasions, develops severe lethargy, decreased oral intake and mental confusion, and brought to the emergency department. ECG and the biochemical test were done. The ECG electrolytes shows severe hyperkalemia and metabolic acidosis. ECG shows, you see from the tracing, that first impression we are seeing here the tall peak T wave. There is tenting effect of the T wave. You are seeing that there is slight broadening of the QRS complex here, and P wave are seen, and there is first degree heart block. There is slight prolongation of the PR interval, and there is axis a bit towards the left, that is left axis deviation. So here the changes are tall peak T wave, tenting of the T wave, slight broadening of the QRS complex, and there is prolongation of the PR interval. And this patient after admission shows a brief period of sine wave. Here you see from broad QRS complex, and it is going to much broader. This is sinoventricular rhythm, we will see later on. Then ultimately it turns into a sine wave, that is upturn and the downturn. With empirical treatment with calcium, insulin, dextrose, patient shows there is much normalization of the previous changes, particularly concerning the QRS complex a bit smaller in the shorter in duration, but T wave still remain a bit peaking. T wave still remain peaking, but there is shorter PR intervals and disappearance of the sine wave. After dialysis, there is complete resolution of the hyperkalemic, all the changes, although there is some hypertrophic changes is there, but T wave is getting smaller and it is of normal amplitude. Next case is 72 years old male suffering from heart failure, hypertension, type 2 diabetes mellitus on enalapril for hypertension, spironolactone and metoprolol for heart failure. So we know that the patient getting enalapril can produce hyperkalemia, spironolactone can produce hypokalemia. These are two commonly used drugs. And ABG shows potassium was 9 millimole per liter, and the patient blood sugar was 32 millimole per liter. The patient was diagnosed as a case of diabetic ketoacidosis and hyperkalemia. You see the ECG that the important changes are the tall T waves along with very broad QRS complexes with absence of the P wave here. So there is broadening of the QRS complex, absence of the P wave, and there is tall T waves. A 70 years old male getting chemotherapy for non-Hodgkin's lymphoma present to the emergency department with multiple joint pain and swelling and giddiness and pre-syncope. He is also having the difficulty in breathing. First ECG shows there is no P wave. It appears that it's a case of junctional rhythm, but striking thing is that there is the Eiffel Tower effect of the T wave. That is T wave getting larger and tip is more pointed and the base is relatively narrow. And a bit widening of the QRS complex. The second ECG, after a few minutes, it shows severe junctional bradycardia. So considering all the facts, they are thinking about doing temporary pacemaker, considering it's a case of 6 sinus syndrome. But at the same time, they are doing the investigation and the reports come. Potassium shows 7.9 millimeter per equivalent per liter, creatinine 3 milligram, uric acid 12 milligram per DL. So it was a diagnosis of tumor lysis syndrome, resulting in massive tissue breakdown and hyperkalemia. And after normalization of the potassium, you see the almost all the changes gone up except the pointed T waves. Now we have seen a range of ECG findings is there. I'm not going in details, but the striking findings. What are the striking findings in case of hyperkalemia? These are the tall peak T wave and the T wave peaking persists and worsens with increasing hyperkalemia. There is shortening of the QT interval, and QRS will gradually get wider, POI will be broad, and eventually POI will disappear, resulting in sinoventricular rhythm. The QRS will be wider further, and the S wave continues into the T wave, resulting in sine wave curve. And ultimately, when the potassium gets more and more than 8, 9, or 10 milliequivalent per liter, patient may develop cardiac arrest, resulting from ventricular asystole or fibrillation. Again, by seeing the ECG, we can have a knowledge about the biochemical level of serum potassium. When we are seeing only changes is in the T wave and PR segment to some extent P wave, then we have an assessment the patient has got mild hyperkalemia. When there is broadening of the QRS complex and there is involvement of the ST segment in the form of shortening or elevation, and there is loss of POF, then we have to think about patient probably have moderate hyperkalemia. But when the patient progressive widening of the QRS complex resulting in bundle branch blocks, resulting in sine UIF and ventricular fibrillation, then it is almost certain that we are dealing with the case of severe hyperkalemia. So this is one picture which can depict all the things at a time. Thus, when the potassium level ranges in between 5 to 6, we are observing that the T waves is peaking. When it is in between 6 to 7, yes, there is change in the P wave is gradually smaller and it will disappear ultimately. When it ranges between 7 to 8, widening of the QRS complex will be started. And when it more than 8, you see that there is sine wave pattern and ultimately leads to development of ventricular fibrillation and cardiac asystole and death. So how all the things are happening inside? These are the some, in short, the electrophysiological mechanism of how the increased potassium may produce all the changes. It affects the phase 0, phase 2, and phase 3 of the action potential phases. And the extracellular potassium rises, the ratio between the intracellular and extracellular potassium is decreased, and the resting membrane potential become less negative. So this will affect the height and velocity of the phase 0 of the action potential. So there will be slowing of the conduction velocity, the atria ventricle, and will cause widening of the PUF and QRS complex. When it affects the phase 2, there will be faster and shortening phase 2, which is equivalent to plateau phase, resulting in shortening of the ST segment and shorter QT interval. In phase 3, there is rapid and shorter repolarization because in presence of hyperkalemia, there is conductance of the potassium across the cell membrane increase, so more potassium will be flushed out. So there will be shortening and steepening, steeper downslope of the action potential curve here, resulting in peaking of the TOA. The hyperkalemia affects cardiac transmembrane action potential differently. You see this scale here. The potassium sensitivity to atrial muscle, ventricular muscle, AV ventricle, and AC node are not the same. The sensitivity is mostly in the atrial muscle, second ventricular muscle, and the least resistant is AC node. And we'll see how they affects the conduction system and the rhythms of the heart later on. So the special attention will be in case of hyperkalemia. The special changes are tall peaking TOF, sinoventricular rhythm, sine UF, and the pseudo-infarction pattern resulting from ST elevation in V1 and V2. So what is tall peak TOF? We all know. Peaking of the TOF is the earliest to occur and worsen with increasing hyperkalemia, often described as tenting, because they closely resemble the shape of a tent. They are tall and symmetrical, tallest in the precordial leads. They have got pointed tip. That's why they are called as Eiffel Tower effect on the TOF. Narrow base definitely, steep ascent and descent is there. And the TOFs are often taller than of the QRS complex in the precordial leads. The diagnosis of hyperkalemia basically is unthinkable or untenable unless there is any TOF change. The TOF has got a multiple causes of the peaking of the TOF, among which hyperacute myocardial infarction may induce some TOF changes. In hyperkalemia definitely, and the normal variant also may have some cases there may be also TOF, large TOF or peaking of the TOF. This is a bit at a glance there are differences between the two. Most important thing one is that the base is narrow and the apex is pointed or tip is pointed, whereas in hyperacute, all it has got a broad base but the blunted apex. At the same time, there should have some evolutionary change and also some change in the R wave, particularly when it is associated with acute myocardial infarction. There will be associated change with the R wave and also QT interval, which is prolonged in case of hyperacute myocardial infarction. Second important change is sinoventricular rhythm. For the students to know about that, you see the ECG tracing, where you will not find any P wave. No P wave here. The QRS complexes are very much broad and rate is very slow. So what is sinoventricular rhythm? The absence of P waves in hyperkalemia, even when the rhythm remains normal sinus, is called the sinoventricular rhythm. What does it imply? It implies preserved sinus node function with conduction of the impulses to the AV junction without generalized atrial excitation, which I previously told that the atrial muscles are very sensitive to the hyperkalemic changes. So in this phase, sinus node is active. It is producing its impulse, but atria remain paralyzed. So there will be no P wave generation. The impulse propagation in such cases is presumably via the specialized internodal tract. So it passes through the specialized internodal tract to the junctional tissue and to the ventricular tissue. So there is ventricular complexes, but there is no P wave. So it is called sinoventricular rhythm. You see here, when the QRS complexes are no longer preceded by P wave, then the rhythm is impossible to differentiate from AV junctional rhythm. Here you see these complexes are narrow and there is no P wave. And at a first glance, we have to tell it that the patient has got junctional rhythm. At the same time, picking of the T wave is there to explain hyperkalemic changes. On the other hand, when the complexes are broad, then it will be very much difficult to differentiate it from accelerated idioventricular rhythm. Then sine wave. What is sine? Sine is basically a mathematical curve. It has got an upslope and the downslope, just like a line which is going up and going down. The characteristics of the sine waves are when there is extreme wide, more than 0.20 second, and basically it is produced due to merging of the S wave of the QRS complex with the T wave, resulting in a single line. Complete loss of visible atrial activity on the ECG. What does it depicts or what does it indicate? It indicates worsening cardiac conduction delay from hyperkalemia, and it occurs when the potassium level goes to extreme level, more than 8 milliequivalent per liter. The first one is sinoventricular rhythm ECG tracing, and second one again is a tracing of the sine wave. Hyperkalemia sometimes may produce ST segment elevation, particularly in the right-sided chest lead, but maybe in inferior leads also. It is so striking that it raises the possibility of coexistent acute myocardial infarction as well. So sometimes it is very difficult, and sometimes patient need to have emergency coronary angiogram to exclude the possibility of acute coronary syndrome. How it is produced, mechanism is unclear, but probably the shortening of the phase 2 of the repolarization phase, producing shortening of the ST segment, and at the same time there is peaking of the T wave. So the T wave is gradually gets peaker and peaker, and it tried to pull the ST segment up as well as the QRS later part of the QRS complex to pull it up. So it looks like ST elevation. Basically, it is due to hyperkalemic changes. So you see the ECG here. There is anteroseptal simulating the anteroseptal myocardial infarction and hyperkalemic patient. After correction of the potassium, you see there is almost normalization of the ST segment in the V1. This is simulating. This is very much classical, simulating acute inferior MI, because you are observing that in the ECG there is in lead 3 and lead AVF there is ST elevation, and on the other side there is reciprocal ST depression in the 1 and AVF, which raises the strong possibility and doubt of inferior myocardial infarction. On the same time, there is ST elevation in the V1 and the depression in the V2 and V3. So there is strong doubt, but this patient is suffering from Addison's disease, important cause of hyperkalemia. He has got dyslipidemia, getting high dose statin therapy, developed probably rhabdomyolysis, ultimately leading to severe hyperkalemia and the ST wave changes. And after correction of the hyperkalemia, not correction, but after giving the intravenous calcium administration, the ST changes disappears, although the potassium still remains high. And rarely in hyperkalemia in certain cases may lead to changes simulating the Brugada syndrome. You see in the V1 and V2, there is a right bundle branch block pattern of the changes in V1 and V2, ST elevation 2 millimeter or more, and the T of inversion. These changes sometimes may occur in hyperkalemia. So all these are changes due to hyperkalemia. Now we'll go to hypokalemia. What is hypokalemia? When potassium level goes below down 3.5 milliequivalent per liter. In again 3 types, mild, moderate, and severe. Severe we call when less than 2.5. And the ECG changes usually does not occur until it goes below 2.7 milliequivalent per liter. And the ECG changes does not normally correlate well with plasma concentration as it occurs in hyperkalemia, and is an unreliable guide in the diagnosis of the hypokalemia. Young men of 22 years presented with the features of acute gastroenteritis with hypovolemic shock and extreme muscular weakness. And along with other biochemical tests, ECG has been done. It shows that ST depression is very much marked here with T inversion and the prominence of the U wave here. At the same time, there is long QU or long QT interval. A patient chronic diarrhea with weight loss and anemia who is suffering from the villus adenoma of the colon, one of the important intestinal colonic disorder that is responsible for potassium losing gastroenteropathy. This patient's ECG before doing the colonoscopy reveals that the patient has got T wave inversion with appearance and prominence of the U wave in certain leads with long QT or long Q interval, and the patient has potassium level 1.9 millimole per liter. The patient who is suffering from DCM is congestive heart failure, having loop diuretic for a long period over 5 years, developed extreme weakness and lethargy, because the loop diuretics is one of the important drugs which is responsible for hypokalemia. You see there is prolongation of the QT interval and atrial ectopics causing R1T phenomena predisposed to development of the torsades de pointes. So what are the ECG changes in hypokalemia? There is a lot of ECG changes, but the vital one or striking changes are affecting the P wave, affecting the T wave, affecting the U wave and the ST wave. You see there is increased amplitude and width of the P wave, prolongation of the PR interval. There may be ST depression, T wave will gradually smaller, become flat, or even become inverted, and there will be appearance of the U wave, and U wave gradually gets larger and larger. And ultimately, with worsening hypokalemia, there will be supraventricular, ventricular ectopics and tachyarrhythmias, ultimately leading to life-threatening ventricular arrhythmias. So in a picture, you can see that in decreasing potassium level in a patient with hypokalemia, T wave shrinks, become inverted, U wave appears and will grow further. There will be fusion of the two waves, and there will be prolongation of the QT or QU interval. Same thing you are seeing according to level of the potassium. So interesting thing is that how the potassium deals with the T wave. It is called pull and push effect. And the potassium level rises, that is in cases of hyperkalemia, potassium tries to pull the P wave, producing peaking of the P wave. On the other hand, contrary, the less potassium or hypokalemia will push the T wave, goes to baseline, become flat, and ultimately it may become inverted. This is called the pull and push effects of the potassium on the T wave. How it affects the action potential? So it is just contra to the affection of the hyperkalemia, but slope of the phase 2 action potential here increases. This is responsible for prolonged QT interval. Phase 3 of the transmembrane action potential deviation decelerate and become less steep, resulting in low amplitude T wave. So hypokalemia in different ways gives rise to development of reentrant tachyarrhythmias. We show the different mechanism. I will not go in details. Hypokalemia affects the sodium potassium pump. When there is less potassium, there is decreased activity of the sodium potassium pump. That will activate the more sodium calcium exchange, calcium overload delayed after depolarization. Hypokalemia, when there is potassium less, there is conductance across the cell membrane of the potassium will be decreased. That will prolong the repolarization phase. So early after depolarization will be produced, so there will be more chance of development of arrhythmia triggering. So hypokalemia in various ways can produce reentrant tachyarrhythmias. In hypokalemia, our special attention about the U wave, as because the U wave which are produced in hypokalemia is larger and is large amplitude. So genesis of the U wave, does it differ from normal person? In a normal person, what is the what are the hypotheses? There is no exact reason for origin of the U wave in a normal person, but there are three main hypotheses. Most popular one is that it is produced because of the late repolarization of the His-Purkinje system, late repolarization of some portions or cells of the left ventricle, either septum or from papillary muscle. But the most accepted one is that delayed after depolarization of the ventricular wall occurring during early rapid ventricular filling phase, that is called the electrical diastole, that stretches the myocardium and produces some after depolarization. That is the mostly accepted hypothesis behind the genesis of the E wave in a normal person. But how it is produced, in how it differs from hypokalemic U wave. In hypokalemia, there are two opinions regarding the origin of the large U wave. One is splitting opinion and another is fusion opinion. Splitting opinion is that it has been shown that the hyperkalemia, the normal T waves, become interrupted and split into two components, and the T waves represent the first component and the U wave the second component. And another opinion is fusion opinion. The T wave regresses, U wave grow larger, and there is fusion of the two complexes resulting in a large U wave. In the previous slide, we have seen the behind the genesis of the U wave. Normally, it is the most popular one is that the delayed repolarization of the His-Purkinje system is responsible for U wave. But here, there is most popular hypothesis is that there is delayed repolarization of the myocardial M cells, that is mid-myocardial cells, which also shows delayed repolarization rather than His-Purkinje system, because the large U wave, these are very large U wave in hypokalemia. His-Purkinje system contain a small amount of mass, so that mass during repolarization very unusual to give so large deflection in the ECG tracing. So it is the mid-myocardial M cells repolarization, delayed repolarization, which is responsible for production of the U wave in the hypokalemia. So it is not usual U wave that is occurring in hypokalemia. Although the U wave are the most common ECG abnormalities in hypokalemia, but it is not at all specific in all. It may happen in bradycardia, LVH, mitral valve prolapse, hyperthyroidism, even some drugs may produce hypokalemia. Now let us go to calcium level. Calcium is very important cation inside the body, although it remains in the bones, muscles, in the circulation, only 1% remain in the circulation. So normal calcium level is 2.1 to 2.6 millimole per liter. We call it hypercalcemia when it exceeds 2.6 millimole per liter. I'm talking about the total calcium, not the ionized calcium. And the ionized calcium is mainly responsible for the membrane potentials and other things, not the total calcium. And largely, the calcium concentration largely depends on the serum albumin level. That will be calculated after correction of the albumin level. A patient suffering from hypervitaminosis D develop due to overdosing of the vitamin D develops hypercalcemia, because in the COVID era there is increased tendency to take vitamin D in a large dose. COVID has been in our country for the last 6 months. So large dose vitamin D can produce hypervitaminosis D. We should be care about that. So hypervitaminosis D is one of the cause of hypercalcemia. And you see the ECG changes. I receive the appearance of there is sliding of the downstroke of the QRS complex, which is we are calling is J wave, Osborne wave or J wave, provenance J wave. Next, a patient suffering from bronchogenic carcinoma has hypercalcemia as because of paraneoplastic nature of the tumor as well as secondary metastasis to the bone can produce hypercalcemia. Hypercalcemia, here you see there is shortening of the QT interval and there is very striking change in the down deflection of the QRS complex, which we have called this prominent J wave as well as short QT interval. This patient is suffering from parathyroid adenoma, secreting large volume of parathyroid hormone into the circulation. It goes to the heart and produces so visually changes. QRS complexes are broad, and here you see the J waves here on the particularly in the P1, and the QRS complexes you see is very short. A patient suffering from sarcoidosis with systemic hypertension getting hydrochlorothiazide for more than 5 years. Sarcoidosis is one of the important causes of hypercalcemia, and on the other hand, hydrochlorothiazide produces calcium retention and hypercalcemia. So you see the broad-based T wave as well as there is appearance of the J wave here. So there are a lot of changes affecting many of the waves and the intervals, but the important one is there will be shortening of the ST segment and there will be shortening of the QT interval. At the same time, there will be prominence of the J wave, and if we look at the T wave, there will be a bit flattening and widening of the T wave. Prolonged peer interval and widening of the QRS complex is also an important feature, and ultimately, in certain cases, there may be elevation of the ST segment in the anteroceptor lead, giving rise to again confusion about the acute myocardial infarction. What is the basic cause? We see from the action potential curve that the calcium has got role only in the phase 2 of the repolarization phase. So here there will be shortening of the phase 2 of the action potential, resulting in shortening of the QT interval. So what are the special changes here? Osborn wave and pseudo infarction pattern. What is that Osborn wave? We are in a short, this is the J point, and this is the J point. It is more prominent. When the J point become more prominent, giving us to wave, then it is called J wave. This is the J wave, and these are the J point, which are prominent points. How it is produced? It is a deflection with a dome or a hump configuration occurring at the RST junction on the ECG. It is pronounced in anterolateral and inferior leads. J wave is also known as the Osborn wave, late delta wave, K wave, H wave, or hypothermic wave, because it is classically described scientifically in hypothermia. In the setting of hypothermia, this phenomenon is thought to be most specific. It is not only found in hypercalcemia, but also found in hypothermia, benign early repolarization syndrome, Brugada syndrome, and subarachnoid hemorrhage and active pericarditis. This is the eponymous history of the Osborn wave. We are not going in details about that, but although the Osborn wave has been named after the Osborn, who studies the effect on hypothermia, and he described this as a deflection of the current of the injury due to current of injury. But first it was described by Cross in a patient with hypercalcemic conditions. But due to systemic and scientific way of research, the wave has been named against the Osborn. But in 1996, Jan and Angel Hitch provided the best explanation for production or pathogenesis of electrophysiology of the Osborn wave. He described that the transient outward current mediated spike and dome morphology of the action potential across the ventricular wall underlies the manifestation of the electrophysiographic J wave, and the presence of a prominent action potential notch in the epicardium and not in the endocardium is shown to provide a voltage gradient that manifests as J wave or an elevated J point in the ECG. You see in this picture, the epicardial, endocardial, and the myocardial potential differs, and it is the epicardial region where there is marked notching of the action potential notch, and this produces transmural voltage gradient, which is responsible for producing a J wave in the ECG, J wave deflection in the ECG. You see a patient with hypercalcemia having anteroceptal in anteroceptal leads, there is marked elevation of the ST segment in V2, V3, even in V4. After normalization of the calcium level, you see there is ST comes down to its normal isoelectric point. It is hypothesized that how the in hypercalcemia there is ST elevation. It is hypothesized that the short ST segment of short QT interval causes the T waves to be pulled at the end of the QRS complex, and the initial upslope of the T wave causing the appearance of the ST segment elevation. So here the possibilities or explanation for ST elevation is that the hypercalcemic shortening of the ST segment pull the T wave closer to the QRS complex, and the ascending limb of the T wave is mimicking the change of the ST segment elevation in anteroseptal leads. Other possibilities are there. You see the other possibilities. I'm not going there. I'm going to hypercalcemic changes and as well as hyperkalemic changes. You see in the hyperkalemic changes, T waves grows and it is become peaker and peaker. At the same time, there is shortening of the QT and it's pulling the ST segment, pulling the QRS complex with it. So it is producing ST elevation. In hypercalcemia, you see the QRS complex as if it is pulling the T wave closer to it. So the ascending limb of the QRS, ascending limb of the T wave may produce some false impression about the ST elevation. And what is hypocalcemia? When serum calcium falls down below 2.1 millimole per liter, then we call it hypocalcemia. And the hypocalcemia usually produces remarkable change on the ST segment. The patient with parathyroidism having ST prolonged QT interval of about 500 milliseconds. This patient has got acute pancreatitis leading to hypocalcemia, and here is also prolonged QT interval. The patient has got malabsorption resulting from Crohn's affection of the small intestine, ultimately leading to hypovitaminaceous D. You see here the classical changes: narrowing of the bit narrowing, slight narrowing of the QRS complex, reduced PR interval, T wave flattening, somewhere it is inverted, and there is appearance of the U wave somewhere, and somewhere it is prominent, and the prolongation of the ST segments. A lot of changes in hypocalcemia, but the pronounced effect is on the QT interval, which makes it elongates it and resulting in flattening of the ST segment and prolonged QT interval. T wave, there may be inversion of the T wave or maybe a slight reduction in the amplitude of the T wave. And the AV blocks is an important feature of the hypocalcemia as well. So how it is produced? Prolongation of the phase 2 of the action potential, as if the calcium influx is mainly responsible for this plateau phase. So this prolongation of the phase 2 of the action potential causing lengthening of the ST segments here. So this is a very interesting slide. This slide, the picture itself depicts the important changes resulting from hyper or hypokalemia, resulting from hyper or hypocalcemia. You see here, when there is potassium is increasing, it pulls the T wave up. So important feature is peaking of the T wave, and when the potassium rises, it pushes the T. It is producing flattening of the T wave and inversion of the T wave. When the calcium level increases, it pulls the T wave closer to the QRS complex, and when the calcium level decreases, it pushes the T wave away from the QRS complex, producing long QT interval. Now we shift to magnesium level. Magnesium, although it has got no direct effect on the action potential, but it maintains, it is modulating the activities of the different enzymes, acts as a cofactors for different enzyme systems of the body that helps in transport of the sodium, potassium, and calcium. Normal magnesium level is 0.75 to 1 millimole per liter, and the critical value we tell it less than 0.5 millimole and more than 3 millimole per liter. But important change what is that it is often associated with other electrolyte imbalances like hypokalemia and hypocalcemia, often it confound ECG changes. So sometimes it may be very much difficult to differentiate between the changes of hypomagnesemia, hypokalemia, because the changes are almost similar and they are coexisting in the same patient at the same time. So what are the important changes? You see There will be prolongation of the QT interval here, as well as PR prolongation and widening of the QRS complex. To some extent, ST depression, TY may be inverted or low amplitude, and what is striking is that there may be precipitation of the supraventricular and ventricular tachyarrhythmias. So you see the pathogenesis, how the magnesium is producing its effect on the cardiac rhythm disturbances, hypomagnesemia, intercellular magnesium depletion, which produces disturbances in the activity of the sodium potassium exchange system by ATPase disturbance in the ATPase system. So reduced intercellular potassium, increased risk of cardiac arrhythmia. And for the same reason, there is inability of the kidney to retain potassium, so hypokalemia, and there is increased risk of the cardiac arrhythmias. Ultimately, may lead to sudden death of this patient. At the same time, magnesium has got some action on the coronary artery tone. Sometimes hypomagnesemia may produce coronary vasoconstriction, as well as some postulates that magnesium as an initiating factor sometimes may play a role in the progression of the coronary atherosclerosis. The malabsorption is one of the cause, and the proton pump inhibitor, if the person or the patient taking proton pump inhibitor for a long period, they may also suffer from hypomagnesemia. So you see the ECG, atrial fibrillation with pulse ventricular rate, and there is normalization of this rhythm after correction of the magnesium. Second, you see that there is patient is suffering from carcinoma of the stomach with gastrocolic fistula. Inside fistula is an important cause of hypomagnesemia, and patient is on nasogastric suction. That is another precipitating factor for hypomagnesemia. And total parenteral nutrition, patient is on total parenteral nutrition. That all the things in combined leads to development of hypomagnesemia, which is causing the long QT interval of 5-10 seconds, which ultimately succumb, which ultimately turns into Trotsky's repointis. So hypomagnesemia affects the sodium potassium ATPase system. I have already told. I will not take any more time here. Hypermagnesemia is a very rare occurrence. Isolated hypermagnesemia is very rare. We called it mild when more than 1, called it severe when more than 2.8. Magnesium usually produces a depression over the conduction system of the heart, producing first degree AV block, broadening of the QRS, and prolongation of the QT interval here. But important change is that it is maintaining T wave upright, and there may be peaking of the T wave as well, as hyperkalemia. So it is very striking change, because the changes in hypomagnesemia and hypermagnesemia is more or less same, except the T wave changes. Hypermagnesemia is a very rare occurrence, and it is possible in case of chronic kidney disease. This patient is suffering from steroid-resistant focal segmental glomerulosclerosis, resulting in the end-stage renal disease. He is on cyclical continuous peritoneal dialysis, and first ECG shows that there is tall T waves, broadening of the QRS complexes, and somewhere there is missing of the ventricular impulses, atrial impulses to go down to the ventricles. Irregular conduction with escape beats, and after normalization of the magnesium by emergent dialysis, you see these changes disappears, but there are certain changes affecting the ST segment and the T wave here. Hypothyroids are more susceptible to develop hypermagnesemia, as well as those patients who are getting lithium therapy, as well as those patients getting magnesium containing cathartics or laxatives. This patient has got hypermagnesemia with prolonged QT interval. Now sodium, although sodium is very abundant in our body in the extracellular fluid, but its affection to the action potential is less. Increased or decreased sodium levels do not have any impact on the ECG, nor cardiac rhythm, nor on the impulse conduction. However, there are few case reports. What are those? These are case reports, hyponatremia presenting as a cardiac conduction defect. You see the patient presenting with complete heart block, suffering from severe hyponatremia. How hyponatremia affects this? It is due to fact that the hyponatremia, due to reduction in the level of the sodium, the zero phase of the action potential become slower, and delayed, that ultimately leads to prolongation of the QRS interval and affection on the conduction system of the heart. In another case report, you see there is P-wave alternance in a patient with hyponatremia, and suspected hyponatremia in a patient who ultimately leads to development of the Bugada phenocopy type of QRS changes in the right-sided chest leads. Now, the extreme hypernatremia is a probable cause of fatal arrhythmia. Why we are telling is extreme? When the sodium level exceeds more than 190, then it is called extreme hypernatremia. There is fatal arrhythmia. You see here the sinus tachycardia, which ultimately ST segment depression, prolongation of the QT interval, ultimately leads to development of sine wave, and patient develop cardiac arrest and death. In extreme hypernatremia, you see the sequential ECG changes. When the patient was admitted, the sodium level was 254 millimole per liter, and there was sinus tachycardia, shortening of the PR interval, ST depression, T inversion. So, and before discharge of the patient, the sodium level was quite corrected. It goes down to 140 millimole per liter. Sinus tachycardia persists, and all other changes, ST-T changes, and the shortening of the PR interval become normalized. So these are the few case reports of hypernatremia. But theoretically, sodium usually does not produce any electrocardiographic changes. Before that, there is marked changes in the central nervous system, and the patient usually succumbs from other disorders rather than the cardiac disorders. So at the end, this is the conclusive slide. In a nutshell, we are seeing the changes here. I'm not going in details. These are the few important changes which are very essential to memorize for instant diagnosis of the ECG changes of the hypo or hyperkalemia or calcemia or magnesium. So all this is the last slide of my presentation from electrolyte imbalances. I think my time has been finished. I have got other slides in extracardiac disorders like thermal disorders and others. Should I
think
proceed further, or I should
we have
stop
got
here?
2 more sessions after that. And Abdul Wadud Chowdhury sir, should we finish here, sir?
No, Firoz, I think we can arrange another lecture for Khalequzzaman.
Okay,
Wadud
sir.
bhai. And because there is a big chapter, pulmonary disease, ICU, that is the ECG in the ICU setting, there are some good topics to discuss. Khalequzzaman.
I think we will finish here today for Dr. Khalequzzaman, and we'll listen to Dr. Khalequzzaman another day. He has given a beautiful description of all these electrolyte imbalances, starting from potassium, calcium, and magnesium, and also sodium. And hence he has given
detail I haven't ever heard.
Exactly, sir. He has shown also number of cases where these electrolytes happens and how it is corrected, and the ECG was normalized. May I request Dr. Khalequzzaman to stop sharing his screen, and we can go for some question and answer sessions. We have got few questions on the topic. One of the question is from Professor Abdul Wadud Chowdhury. What is tall T wave? How tall is tall? Dr. Khalequzzaman.
Literally, we in limb leads and the chest leads, the chest leads are more closer to the chest wall. So here, when the T wave amplitudes exceeds more than 10 millimeter, then we call it tall T. And in the limb leads, when it exceeds more than 5 millimeter height, then we call it tall T.
Thank you, sir. Thank you, Dr. Khalequzzaman. There are some other questions.
Slideshare. Slideshare stop.
Yes, slide sharing has been stopped. Okay. How do we diagnose a case of acute enteroamine from hypercalcemia infarction and hypercalcemia ECG?
Hypercalcemia ECG. Yes, there is a doubt sometimes when it is associated with ST elevation. ST elevation is not a very much common accompaniment of the hypercalcemia, but when it happens, then we have to differentiate from clinically from the history, ECG exam, and other biochemical tests as well. By seeing the ECG, our today's discussion will be limited on the ECG findings. In hypercalcemia, there will be shortening of the QT interval, and the T wave, there will be no change. And you will see that the QRS complex, as if the QRS complex is trying to pull the T wave closer to the QRS complex, and the ascending of the T wave is mainly responsible for simulating the infarction pattern in acute hypercalcemia or chronic hypercalcemia. On the other hand, in acute myocardial infarction, ST elevation is associated with lengthening of the QT interval, and at the same time, there will be change in the T wave. There will be hyperacute T wave changes, and others are evolutionary changes, and from the history as well. So ECG will show short QT interval, and the T wave will be much prominent in hyperacute myocardial infarction.
Thank you, Dr. Khalequzzaman. I think we can take some comments from our experts. May I request Dr. Rafiq Ahmed sir to say a few words about today's lecture regarding how it is important about the ECG changes, to know the ECG change in electrolyte imbalance.
Thank you. This is a wonderful lecture. I mean, the thing is that electrolyte abnormality, we cannot see it when we examine the patient. So our job is, when we look at an EKG, to suspect it. And then every time I look at an ECG, which I think is hyperkalemia, hypokalemia, hypercalcemia, or hypocalcemia, I can never be sure. So I will immediately go back and look in the computer to find out the patient's laboratory finding. And let's say in hyperkalemia, you see these bizarre looking QRS complexes, you have to make sure that the patient is fine and get the ECG. So this is, I think, is a wonderful lecture. And this is ongoing. I think we'll have, I mean, remember one thing, that we will never master ECG, or as a matter of fact, anything in medicine. I mean, it's an evolving field. We have to continue learning. I'm sure if I give an ECG to Dr. Khalequzzaman, Dr. Professor Wadud, or our faculty, or sometimes we'll get confused with this. Thank you. Wonderful talk.
Thank you, sir. We have got Professor ATM Khalilur Rahman, sir, which is the Professor of Anesthesia. Sir, are you with us? Professor Khalilur Rahman, sir?
Yes, I am with you.
Sir, sir, can you have some comments on
Actually, I joined lately. I listened last 5 minutes of the lecture, but I believe it was very informative and useful to everybody. And I am a person who deals the arrhythmia every day. This is my profession. Actually, what happens, I am just outside the operation theater now. I finished 2 CBG 1 hour before. And you know, this time the CBGs are beating heart surgery. So they handle the heart, they make arrhythmia. We have to treat instantly. So we should discuss all those things in another session, definitely. And even, you know, in the morning, we did 1 aortic valve replacement. And any patient on cardiopulmonary bypass, we have to give some diuretic, mannitol, to perfuse the kidney and the peripheral circulation like this. So that makes electrolyte imbalance. And we always try to balance that one by repeating the electrolyte test every hour during the surgery. And all my staff and even the perfusionist, the technologist, they know how to manage this potassium deficiency when it happens. And even what happens today, the patient was hypothermic. And my junior anesthetist, he started the pacing. I told him, why you are doing pacing? the temperature is still 33 degrees. Can come to 36. Then we'll see. I stopped the pacemaker, and when the temperature was 36, it was sinus and 90 per minute. So there are a lot of things happening with the heart, with the people they are handling the heart and the cardiologist, even the cardiologist and the team.
Thank you, sir. Thank you for nice opinion. May I request
just 1 minute more. 1 minute more.
Sure, sir. Sure,
my internet is at problem. So what happens? I want to emphasize, even in the world or anywhere in Bangladesh, till now we are not using the invasive method of gross electrolyte imbalance. We are giving the salines. That is not at all advisable. Now the pump and other HDO services available, and every unit and hospital must know how to increase the potassium or decrease the potassium or increase the sodium efficient and safe. So I request everybody to ventilate all these things. Now things are available. Our juniors must and the nurses staff must understand it. I saw more than 15 patients died due to over infusion of potassium. In my
thank you, sir. May I request Professor Chowdhury Hafizul Hasan to give a brief comment on the subject. Chowdhury.
So I actually enjoyed the lecture and it was brilliant. But few practical things that I actually mentioned in the question and answer session, but I don't know how much time I have. But I wanted to share something with you guys.
We'll give you some time after the session of Dr. Rafiq Ahmed, sir. We'll give some time for showing that. May I request Professor Abdul Wadud Chowdhury, sir?
I promised the audience there will be an in-depth lecture. I think my promise is fulfilled. We really enjoyed. The most important thing is the underlying cause and mechanism. He has explained that nicely. We know about ECG changes, but we don't pay too much attention to how it actually occurs. And today's lecture has given us a glimpse of that. I think we should start Rafiq sir's session.
And then I comment something?
Sir.
I think Hafiz has, I talked to Hafiz, he has a couple of ECGs.
Yeah,
I think it's better for Hafiz to show those, because after my session, everybody will be so tired that it will be time to go.
Okay.
And my session never ends.
Okay, we'll start with Chowdhury Hafizul Hasan, sir. ECG. Sir, you can share your screen.
I'd like to see the practical things from Hafiz, sir.
Yeah.
By the time he's sharing his screen, may I request Atahar sir to say a few words?
Okay. Actually, this is I am always confused about this chapter. Particularly ECGs of this chapter. Sometimes I suspect, then I go back, I see the reports, then again I see the ECG, and then I comment. This is such type of chapter. Many a times I did. I most of the time, sometimes I see this is a ECG of the Hyperkalemia, but I'm not sure. Then, so from actually Khalequzzaman's lecture has given many of the questions of many answer to many of my questions. It was an amazing and excellent lecture. Actually, I have got answers to many of my questions. Thank you, Khalequzzaman, for your excellent and brilliant lecture.
Thank you.
And Mohammed Firoz, actually,
yes,
you don't forget to take some comments from the Kanis Fatima, actually, who is very much, actually, he is everyday practice about this issue, Kanis Fatima.
Dr. Kanis Fatima, you can make some comments about your experience with in ICU regarding electrolyte imbalance and ECG, how much it is helpful for you.
Thank you. Thank you, sir. Actually, in our ICU, most of the time, we face patients with hyperkalemia most of the time. And Hello?
Yes, we are listening to you.
Hyperkalemia most of the time, and very few cases of hypercalcemia. I'd like to ask here Atahar sir and all other Wadud sir, Prof sir and other cardiologists who are present here. As I work in the Bardem Hospital, we do not have pacemaker facility or cath lab facility in our hospital. There is adjoining Ibrahim Cardiac Hospital. So what we face that in case of severe hyperkalemia, patient usually present with sometimes severe bradycardia. In that case, should we start dialysis first? Wait, because each session of dialysis takes 4 to 6 hours, sometimes 8 hours in case in slow sustained dialysis sled. So should we wait for that time or refer the patient with any other ICU with TPM facility?
Dr. Fixab, would you please answer this question? Hyperkalemia with bradyarrhythmia, should you send the patient for pacemaker?
In our institute, we do not have facility for pacemaker.
Sure.
Okay.
I mean, two things.
Probably you have got the question. So Fixab.
This is a patient with renal failure you are talking about. So there is no quick way of decreasing. So one of the things that we can do, first of all, is the patient symptomatic? We have patients with heart rate of 30 doing fine when lying in bed. So we don't rush into putting anything. As soon as we correct the potassium, they'll be fine. If there is no time, and I'm sure not even in Bangladesh, even here we have problem. So what they do, they give calcium gluconate and insulin in the ear. That can reverse part of the effect and increase the heart rate. And in some cases, we do put a temporary pacemaker until everything resolves. But I think if a patient is heart rate 30, I know it is a little bit nerve-wracking if the patient is not symptomatic. And the other choice, I know the Ibrahim Cardiac Center is very close by, but even in our hospital, to transfer patient from one unit to another, it takes time. So I think having dialysis and lowering the potassium is the best thing to do. And the other thing, I don't know if you have it, we always put transcutaneous pad on the chest, but that modality is not, it doesn't always capture. That is the problem part, but at least that is one thing that can be used. Most of the current defibrillators have a transcutaneous pacing, but my rule of thumb is put the pad on, but don't use it because it is extremely painful. Thank you.
Thank you, sir. Actually, we can wait at heart rate 45, but if the heart rate is below 45, it's really, as we have mentioned now, breaking for us.
Okay, if you stay in my question answer session, my session, we'll have some interesting ECGs. We'll talk about it.
Thank you, sir. Thank you, sir. I think Professor Chowdhury Hafizul Hassan can show his ECGs now.
So this is a very not uncommon situation that we see this kind of polymorphic VT, and we had another board question showing that tracing, and it was actually an artifact. So when it happens, then you look at the patient, that one of the way that patient lost pulses, passed out, and then you evaluate the patient, and then my question to you, what do you do then? That the patient doesn't have any pulse, passed out, and then what do you do then? But if the patient has pulses now, this episode, then came back to sinus rhythm, blood pressure okay, little dizzy, but alert awake, what you do then? Because this is something to talk about, and then how we work this up. Any discussion?
Sir, from the next time you can arrange a poll, sir. From the next time.
Oh, okay. But anyone to jump on?
May I request Abdul Jamil, Dr. Sir, to discuss the
Assalamu alaikum. I am sorry that I came a little late, as I came out from the hospital late by 1 hour. So in this tracing, what I see, the upper two panels looks like torsades de pointes. And in the lower two panel, third one is something artificial or something like that. But in the lower panel, it seems normal ECG with undulation of the baseline. So in this type of patient, I should look at the patient's face first, whether there is any expression or not. And I will ask his name and whether he is feeling bad or anything else. If the patient is fine, then the total thing is artificial and nothing to be done.
Okay, so let me tell you what happened to this patient. He's like mid-60s, I think, and then had a little bit of alcohol, came and then lost consciousness and lost pulse. They shocked, and then they called us, and they as Professor Khalequzzaman said that, you know, hypokalemia, hypomagnesemia. They gave, for Torsat they gave magnesium boluses, and they looked at the labs if there is any coexistent hypokalemia. And then this EKG. So I told them to do an EKG, and we have a handheld echo and a CNE regional wall motion, and we brought the cath lab in, and basically this was a very ischemic substrate, LAD ischemia infarct that was treated, and then it got better. So this, I wanted to mention one thing, that hyperkalemia related, as you saw in the EKG, we need to recognize this, because we cannot take this or should not take this patient to the cath lab, because it can be a disaster in the cath lab if we cannot recognize hyperkalemia related. STEMI is two part. It is the ST elevation part and the MI part. So clinical picture is very important. Is the clinical picture is consistent with MI or not? If the clinical picture is not consistent, then we should be thinking about the ST elevation differential. And there are a variety of reasons why the ST elevations can be high, as we learned today, right? Hyperkalemia, hypercalcemia, Brugada can give this picture. We can have persistent ST elevation from apical aneurysm. We can have LVH related ST elevation. We can have early repole. We can have Osborne waves mimicking this. So some are real deal ST elevation, some are like ST elevation mimics. And if we have the patient in front of us, it is very important that we evaluate the patient with the clinical part and then come up with a diagnosis and do this. And if we have a handheld echo, that comes handy, that helps us in terms of, is it a global LV dysfunction, regional wall motion, or the LV function is normal. Or in some cases, for example, in hypercalcemia, you may even see dehydration and hyperdynamic LV. Pericarditis can be confusing with the ST elevation, and that can be another important thing to consider. So we all need to be very careful, and transient ST elevation, of course, can be due to spasm. So this is a case that I will show you. It came up just in New England Journal only a week ago, or maybe this week. So this is a 54-year-old coming following ventricular fibrillation, resuscitated, and then this was found in the EKG. This is a very, very interesting EKG.
May I request Professor Mohsin Hossain? Can you make some comments on this ECG? Professor Mohsin Hossain?
Sir, Firoz. Sir, before commenting this ECG, can I ask a question, sir?
Yeah.
Sir, regarding your first ECG.
Yeah.
Sir, that ECG was described by the Dr. Jamil. Sir, it will take time to get the lab report. Unless you get the lab report, we are not sure. If the patient only has got the shortness of the breath, no anginal statement like this, that is no symptom suggestive of the acute coronary syndrome. No acute coronary syndrome, patient has got the shortness of the breath. This is the ECG. It will take time to get the lab report. So what I do, sir, at this time?
So, Atahar bhai, this is actually a board question in internal medicine here. If the patient is not unconscious or this is happening recurrent, the first thing they ask you is give magnesium.
Right, sir.
Yeah. So I don't know, Rafiq bhai, do you have any comment? But if
No,
the patient unconscious, yeah, go ahead.
Yeah, magnesium is something that will not harm the patient and actually has tremendous benefits. So I think infusion of magnesium is something that should be seriously considered while we are waiting for the labs.
It's been said that magnesium is a cardiac sedative.
Yeah, well said, Wadud, well said. So this EKG was following the ventricular fibrillation, and they said that there may be some ST elevation. I don't know. You can see my pointer.
Yes, we can see.
AVL is like ST elevation maybe, but importantly, and Rafiq Bhai, you can make a comment that there is looks like a right bundle and then left bundle, alternating, somewhat, and then because of the we the plumbers, the interventional cardiologists, we are dumb. And it's the VF, so okay, take to the cath lab. And the patient passed out, unconscious, so they did a CT. I'm not a neurologist, but the CT was negative, and the coronaries were, of course, normal, but the LV function was really bad. And they put an impeller. But look at this, forget about the impeller part, but look at the EKG, alternating. See that alternating?
Yes.
So what does it remind you? Something alternating bundle type? Does anything reminds you? Then I tell you, I struggled with this case, but I was thinking that this is like alternating bundle. The patient took was on any digoxin, but he's a relatively young guy, had no cardiac history, was not on any medication. But it's kind of interesting, is it? Look at that how it is alternating, So it turns out to be that his potassium was very low, and very low, despite correction, remained low.
Spinal electron, that means aldosterone secreting tumor or hyperplasia, something like that.
Okay, so Professor Wadud Chowdhury, as usual.
Oh, sorry.
No, you're right. Let me tell you, as usual, you are pathophysiologically right on the money. It is a hyperaldosterone type case,
I would have asked his hypertension history.
Oh no hypertension. So it is same, right? That there was a little bit of acidosis, but look at this. This is all hyperaldosterone excess, profound hypokalemia. You are absolutely right. So aldosterone type thing in the body. So is it digitalis with the sharing the same, or is it high aldosterone with a secondary hypertension, cortisol state, or glycoretinic acid? So this patient was taking excessive amount of what they call is licorice. And the licorice has the same, and he was in protracted hypokalemia, giving this issue with the ventricular fibrillation. And then this is the whole cartoon that NEJM said. It is like a public health safety issue now, and be aware. I thought that it was relevant with Professor Khalequzzaman's talk, that how this metabolic problem can give you a big cardiac issues.
Okay, can you go back to the ECG, please?
Yeah, sure. First one?
Yeah, the first, second. Yeah, this one.
This one.
I mean, no, please go back to this. So, to our audience, I mean, this ECG does not tell us that patient has hypokalemia.
Yeah.
Can you go back, please? Please go back on this. Yeah.
Hey, this one.
I mean, I always tell people, why is it moving?
So another thing, Rafiq Bhai, as you saw in the presentation from Professor
Can you go back on the ECG, please? Can you go back on the ECG?
I have two. Yeah, this one.
No. This one.
Yeah. Oh, why is it moving? No. Yes, this one. Okay.
I mean, I'm staying here.
I mean, if you look at this ECG, what will you think of it?
Well, Rovik Bhai, Atahar Bhai, you guys think one way, me and Wadud, we think another way. Following ventricular fibrillation, I'm thinking, is there any ischemic substrate? Is there any ST elevation?
No,
and
that is true. No, that is why the patient had the cardiac arrest. But if I look at this ECG, let's say you have given this ECG to a physician in Bogora.
Yeah.
What should he immediately think of this ECG?
Yes, that's a good question. Good question. So,
he will make a diagnosis of atrial fibrillation with bundle branch block.
That's one possibility. Second possibility, I think.
About the FE, we have issues because these are actually P wave.
Yeah.
Yes, but Hafiz, you are looking at it retrospectively.
Right.
And carefully looking at, but the question would be that if anybody looking at it suddenly will saw the irregularity and white QRS.
Yes.
My problem with this white QRS, this is a very ugly looking white QRS that we see in two conditions. One, when the patient is dying with agonal rhythm,
right, sir,
which the patient did, or severe hyperkalemia, right?
Yes, sir. Exactly. That's a confusing thing.
I wanted to tell you another thing that Professor Khalequzzaman also mentioned, and we see this in the ER, that when there is a severe acidosis and hyperkalemia, it makes it even worse with the acidosis. And therefore, it is imperative to treat with bicarb when there is hyperkalemia.
Now, I think, Hafiz Bhai,
yeah.
Sir, actually, really it is a good message from Rofik sir to our participant, that is such type of ugly looking ECG. Initially, from cardiac point of view, we take it as a serious ECG. But what I am actually like to comment that this ECG messes more with the hyperkalemia than the hypokalemia.
Right. So, and honestly, if you look at this, no one is disputing that. The reason, when we see the EKG first and the clinical picture, we get fooled, right? That this is a metabolic problem or not. You do whatever you need to do, and then think about this gap. Because look at this. Hey, it's a Mass General. They also got fooled. They did the cap. They found cap normal. And then the correction of the acidosis, and this, look at the QRS become narrow now.
Yeah.
When you see this QRS narrow, you don't feel the differential of hyperkalemia anymore. But what it does in the second panel, that it does give this alternating bundle type. If you look at this, and that raises question, bidirectional tachycardia, bidirectional in the context of DIJ, we all know. But this was very mesmerizing in a way. I mean, that's the reason it went to NEJM. But I thought that it is interesting to bring up all the issues. Rofik Bhai mentioned a very key point, that when the EKG is this ugly, then we need to think about the differential, not to jump on one thing.
Yeah, thank you.
Thank
differential.
Thank you, Professor Chowdhury Hafizullah Hassan. I think we can move on to the next session. It will be ECG session by Dr. Rafiq Ahmed, sir.
So we'll do it half an hour today, right?
Correct, sir.
Okay, so I have just like before, we'll do present some ECGs, and you will. I have given choices.
Shubhra, poll is there. We can do the poll.
Yes. So the attendees can start answering.
Yes, sir. So we can start the poll. We can start the poll, sir.
Yes.
Hello? Yeah.
I think 30 seconds is over. So 40% says it is number 2, that is sinus bradycardia with left anterior fascicular block, and 44% says it is sinus bradycardia with left anterior fascicular block with hypocalcemia, and 20% says it is sinus rhythm with left axis deviation.
Okay, so we'll discuss this. Dr. Khalequzzaman, I want you to comment about this ECG about the choice of D. Do you agree or disagree with this?
So this appears to be sinus bradycardia, left anterior hemiblock, and somewhere there is evidence of the left atrial enlargement. But the QT interval appears to be normal, within normal.
Yeah, I put the QT interval below. It's 498, corrected is 415.
Oh, it's normal.
So it is not short.
Yes, it's normal. There is
other
evidence
thing
of left atrial enlargement, and QRS in the V1, V2, V3. Is a slight broadening of the QRS complex here.
Yeah.
Slight broadening.
So people
and
who
there is
have
persistence of the S wave in the V6 also.
Yes.
This is not usual findings.
Yes. Probably this is lead position. Sometimes people put position in the wrong way. But the question is, hypocalcemia, the ST segment should get long and QT should be long. It is not long.
No, yes.
It's not long.
So I think the simple diagnosis is sinus bradycardia, left anterior fascicular block. Just because today's lecture was electrolyte, I am sure if I get this ECG another day, everybody would have answered number 2.
Yes.
Yeah.
And that was the reason that I gave this ECG. So please remember.
Should you comment on the P wave, sir?
Yes. Yes, the P wave is a little funny looking P wave. If you go by the strict sense, it does not fulfill the criteria of sinus rhythm, because these P waves are changing.
Yes, sir.
Over this P wave in lead 2 and this one, there's a changing P wave.
And the rhythm strip, it looks like bifid, sir. And the lower strip.
One of the things that happens is we consider sinus node as one entity, but it's a long structure. It's a 1-inch structure, and there can be wandering of the pacemaker within the sinus node. It can come from the top, it can come from the bottom, and where it's exiting. And that can give some variation. But for all practical purposes, if somebody calls it sinus bradycardia, left anterior fascicular block, I think that will be the primary diagnosis of this ECG, and we can go into nitty-gritty of this. Now, next one. So this.
Sir.
Okay, start the poll right here.
Yes, sir. We started it. Uh, 30 seconds is over. We can show the result. So 86% says it is junctional bradycardia with possible hyperkalemia, and 14% says it is junctional bradycardia with acute inferior myocardial infarction.
Dr. Khalequzzaman, congratulations. I think your lecture was excellent, and that is the end result of this. So there are, when we give these choices, what are the rationale for this choice? There should be some relation. Sinus bradycardia with intraventricular. Anybody, any comment about this, Dr. Khalequzzaman? Can you say something about this?
No, sir, I have no added comment because the T waves are very much prominent here. There is peaking of the T wave, and there is no discernible P wave in the ECG, and rate is very slow. And there is junctional brady and possibility of hyperkalemia. But there is possibility, there is lead to an AVF, there is a bit ST elevation, which may be explained on only with hyperkalemia event, but there is 1 millimeter ST up in the lead 2 and AVF.
Yes. So it brings us.
Sir, may I make a comment, sir?
Yes.
Dr. Khalequzzaman, you have mentioned a term as sinoventricular rhythm. That means the impulse is generating from sinus, but there is no P wave, and it is conducted in the QRS complex.
Exactly. That may be a possibility.
Is it a sinoventricular rhythm or junctional brady?
Maybe. Junctional, I have told that when the QRS complex is narrow or normal and there is absence of the P wave, that may arise the confusion of the junctional rhythm. So junctional rhythm differential diagnosis may be sinoventricular rhythm. We will consider the peaking of the T waves. So you may tell it's sinoventricular rhythm.
Okay. So I have a question for Dr. Khalequzzaman. So there is a MD student taking final exam, and his answer was junctional bradycardia with hyperkalemia. Will you let him pass?
I'll be happy with only junctional bradycardia. Junctional bradycardia with hyperkalemia, yes, I'll give him pass.
So I actually had another ECG. I did not put it here today. And I looked at a rhythm like this and then magnified it. And sometimes you can see a very shallow P wave with first degree AV block. If you magnify, sometimes, but this one I could not see anything. And I put a diagnosis of acute inferior myocardial because in hyperkalemia we can get ST elevation. So, but we have to keep that in mind in the clinical context, like Hafiz mentioned, that patient is not having chest pain. So I don't have to rush this patient into the cath lab. If this patient is not symptomatic, I don't have to put a temporary pacemaker in. I have to wait for the electrolytes. Other thing, what is a tall T wave? Tall T wave, one of the simple way I look at it, if it is more than the QRS complex, and if you look at V4, look at this. The T wave is bigger than the QRS complex, and that is very much suggestive of hyperkalemia. If you look in V6, it doesn't look very peaked, but in V4 it is. So this is hyperkalemia. This patient's potassium was 7.
Sir, can I make a comment, sir?
Yes, please do.
Sorry, sir. Yes, sir. Inferior myocardial infarction definitely is a differential diagnosis, and that is because of some STT changes in the lead 2, 3, and AVF. But actually, what you explained and what was in the Khalequzzaman lecture, sir, actually, the STT changes are also seen in the hyperkalemia, and in this ECG, sir, there is a clear J point elevation and the J wave in the lead 3. That is the J point elevation with this type of the concave ST segment elevation. I think this is more coincides with the hyperkalemia than the acute myocardial infarction, along with your suggestive symptom.
Absolutely. This brings us to the point that patient is the most important thing. We have to go and talk to the patient. Are you having chest pain or not?
Yeah.
So that's the issue. So this patient, when the potassium, so these are the few findings that already narrow tall peak T wave, intraventricular conduction, decreased amplitude or absent P wave, ST segment change simulating injury.
Yeah.
So when the potassium goes down to 5, you can see that in V4, the T wave is much lower. And this is the ECG several days ago, normal ECG. Now, I have another ECG now. This is a subject who is 36-year-old female. And this is I have the rhythm stream. And what do you think? And this will bring to Dr. Kanis Fatema's question. It will answer something about this.
So 30 seconds is over. You can show the poll result. So it is a mixed result, sir. 37% says it is D, that is sinus bradycardia, and take history and examine the subject. 32% says it is A, sinus bradycardia with long QT interval, possible hyperkalemia. 21% says it is sinus bradycardia, admit to ICU, insert temporary pacemaker, and 11% says it is junctional bradycardia with IVCD.
Okay. Any comment from the panelist?
Sir, why there is no hypokalemia, sir? Is because we can see the E wave.
Yes, that's true. I did not give it by choice. So I'm glad that at least a significant number answered sinus bradycardia, take history and examine the subject. This is an ECG from an elephant. It's an Asian elephant.
ST elevation and QF.
Yes.
We are in electrolyte imbalance, but this thing, I think that may sometimes be important in ischemia, that means inferior MI. In ABF, we can look closely. There is QF and ST elevation along with QF.
Yes, no question. So that's why the history is very important. Sinus bradycardia, take history and examine the subject. This is an ECG from an elephant, not a human being. It's an Asian elephant. Elephants have heart rate of 25, resting heart rate. And please imagine a 5,000 kilogram animal living on a heart rate of 25, and it is not passing out, and it does not need a temporary pacemaker. So whole point is the importance of the symptoms. So I'm going to bring another ECG. The next ECG.
Who put the electrodes on the elephant?
Oh yes. So I'll tell you exactly. I'll bring it. So look at this. This is another ECG. This is a heart rate of 8. This subject is awake and hunting. This is
a whale.
It is a blue whale.
Blue
whale with a heart rate of 8. So this is another ECG, but this subject is at rest, heart rate of 204. This is a 40-year-old female. It is a hummingbird, which is 2-year-old hummingbird, whose equivalent human age should be 40. And this is the hummingbird. The body weight is 3 grams, heart rate of 204. So he doesn't need defibrillation. And this is what happens to whale. The whale, blue whale, when it stays at the surface, the heart rate is 35 to 30. As it dives down to hunt, its heart rate goes as low as 4 beats per minute. The reason I'm showing this is it's interesting that people do so much research, and how do they do this? And this is, look at the size comparison. A blue whale is 180,000 kilogram, and elephant is 50 kilogram, and human being is 70 kilogram. This is a huge weight. How do they do it? For whales, they have suction cup, and they put the electrode in the belly, and they have transmitter which sends the signals, and people recorded them. For the elephant, they have sutured electrode on the skin. I mean, so the whole point is that the heart rate is just a factor. And you know, tennis player Bjorn Borg. Bjorn Borg, he was the best tennis player in the world, and his heart rate, resting heart rate, was sinus bradycardia rate 38 beats per minute. Wow. After playing 6 sets of tennis, his heart rate will go to 78, 80. And he did not need a pacemaker. So please remember it, that the heart rate per se is not the most important factor. It is what?
Symptoms.
Okay, so now,
Can I make a point? Yes. About the temporary wear.
Yes.
Electrolyte imbalance. Sometimes we see that we buy time with and I'm not for a second advocating this, but transcutaneous space and immediately correct the electrolytes. Before you arrange the transvenous spacer, the rhythm is already better.
Exactly, no question about it. Absolutely right.
So the answer for this ECG is, sir, 62% says it is D. That is sinus rhythm, incomplete right bundle branch block, long QT, and possible hypocalcemia.
Oh, fantastic.
Yes.
Dr. Khalequzzaman.
I have got the same opinion here.
Good. So your lecture worked.
Also with me.
So this patient's calcium level was 7. I usually put it in Japanese so that you don't understand what it is. And normal in our hospital was 8.5 to 10.2. And you can see here if you look at this QT interval, let's say V5, the ST segment is long, that T wave did not change much. If you look at long QT syndrome, the T wave will become wide. So that's where you look at to see if there is any difference. And all of this, when I'm reporting this ECG, I will say suspect hypocalcemia, and I will look up the report of this patient.
Excellent, sir.
That means you are saying, sir, in case of congenital long QT syndrome, the T wave, along with the ST segment, long ST segment, the T wave will be changed. But in case of electrolyte disturbance like hypocalcemia, basically the T wave remain unchanged, but the ST segment get prolonged.
Exactly.
Right.
So long QT with the prolongation, there is one type of long QT where there is ST prolongation, but majority there is wide T wave.
Also, you have got Osborne wave there, J wave, in that ECG.
Previous one. Yeah.
Osborne.
Yes. Yes. Absolutely.
V3 classically shows the.
Yes. V3. So this is another ECG. So question, please. Sorry.
So 32% says it is A, accelerated junction rhythm, prominent U wave, possible hyperkalemia. 32% says it is sinus rhythm with prominent U wave, possible hypokalemia. And 26% says it is sinus rhythm, first degree AV block. 11% says it is complete heart block.
Okay. Any of our panelists have any comment about it?
Why is Monwar today? I missed him. Mishkat Bhai, do you want to comment?
To me, it appears first degree heart block.
Anybody? So, I mean,
Sir,
if go ahead,
Atahar, sir, please.
sir, is there any points in favor of the junctional rhythm, sir?
Well, if I don't see, if this is a U wave, this is a junctional rhythm. So,
Yes, right.
I mean, if I look at, let's look at V5. It looks like U wave, right?
Right.
Yes, sir.
And then there is no P wave preceding the QRS, so that should be a junctional rhythm. But what doesn't, I mean, if I look at lead 2, I cannot tell whether it's a P or U. But in lead V1, it's a little funny looking. It looks kind of biphasic, almost like sinus P wave.
Yes, sir.
So in this case, I mean, I can imagine, I will call it sinus rhythm, but I will also look at other ECGs on this patient. And so what happens? This rate was 78, and when it goes down to 71, you can see the P wave much better now.
Yeah.
See? So, and this patient actually had another ECG with a heart rate of 101. It is almost impossible because this patient had baseline first degree heart block. And the reason I'm showing it is when there is first degree AV block and the rate gets fast, it looks like E wave. Sometimes it can look like SVT because I cannot see the P wave. So follow-up ECG is very important on this patient. Thank you.
So generally U waves are more prominent in the mid precordial lead.
Yeah,
and
yeah,
when this dominance and prominence is not present and we have a differential diagnosis of first degree heart block, then we should go towards first degree heart block.
Great. Yes, thank you.
And another thing is that the E wave is generally not sharp or peaked. Yet the waves are actually peaked. And one thing Rafiq sir has always emphasized this. If you want to be sure it's a sinus, look at lead 2, lead 1, whether it is upright, the wave which we presume to be sinus wave, whether it is upright or not. Second, look at V1, whether it is biphasic or not. If a biphasic wave is there and this is upright in lead 1, 2, you can be sure the most likely it's a P wave, sinus P wave.
We have 2 more ECGs, then we'll finish on time. Okay, this one. Sorry, this one. This is. And there is a computer-generated report to help you also.
Or confuse you. Either way.
Seconds. You can show the result. That 44% says it is 2:1 AV block with right bundle branch block, and 33% says it is complete heart block. 22% says it is sinus bradycardia with first degree AV block with RBP.
Any comment from any of our panelists?
Jalfai, do you want to comment?
I'll go with the answer C.
C.
No comment.
Yeah.
So, I mean, let's give analysis the people who said first degree AV block. In their defense, I have first degree AV block. I can see a P wave QRS, P wave QRS. So, in their defense, it is, and PVR looks pretty good. However, if I go this way, I can see that the PR is changing.
Yes.
So that's one. But then again, you can say, well, there can be some variability of PR. Idioventricular rhythm, because it's a wide QRS, but it fulfills a right bundle morphology. Now, 2:1 heart block is a possibility. If that's the case, then this is a P wave. There should be another P wave. And I kept looking at it, and then I found something here. If you can see my pointer, there is a P wave, there is a P wave, there is a P wave, there is a P wave. So then my confusion was, it's 2:1 heart block, but then there is a variability. So what I did the timing of this. If I do the timing, the RR interval is 1,600 millisecond, exactly 1,600 millisecond. And then if I put this initial P wave, the P2P is 1600 millisecond. First two. However, if you look here, 1630, 1640, 1650. So this RR did not match this P2P interval. And I felt like that this was complete heart block. But one can always argue that there is delayed conduction. If that was true, then this RR should have been longer this interval, PR is getting shorter. It does not affect the RR interval at all. So I felt like that this is complete heart block. And if we do longer rhythm strip, we could have seen the clear AV dissociation on this patient.
That's
and
the
then,
next one.
Then you can see put the P waves, and I put the timers here. Interesting thing, look at this. P to P interval changes a little bit. If you look at this P interval that is including the QRS complex, is a little shorter than the one that is not enclosing it. It's called ventrilophasic sinus arrhythmia, that this QRS complex brings the next P a little early, because it is 1640 and this is a little longer. So that is not uncommon to see in this kind of ECG. How about this one? Oh, I didn't put choice. I didn't put any choice. The question was that what it is, and the report was that it was sinus bradycardia with premature atrial contraction. And the point was P wave QRS complex, P wave QRS complex, P wave QRS. Ignore this one, but there is a premature beat. So the report came up as premature atrial complex, non-specific intraventricular conduction delay. I think because of I think this is probably lead position, but it looks like left bundle. However, if I put the timing, This RR interval is 15-20 milliseconds, exactly 15-20, but this one is early, and then it becomes 15-20. And if you look at the P to P interval 760, 760 plus 820, that makes 1580. So that the P to P is not matching with R to R. And I think this is a conducted beat. So this is what we call high-grade AV block. I know if Jamal has any comment on this. Jamil, what do you think?
I agree with you. So this is a high-grade AV block.
This is a question, Jamil, we get all the time. What is definition of high-grade? I mean, we have first-degree AV block, second-degree AV block, right? And then third-degree. But why are we using this term called high-grade AV block? I mean, we use it all the time.
We use as because in the same patient, sometimes it looks like complete heart block, sometimes 2:1. Sometimes they show some bits are conducted, most of the bits are blocked. Confusing. That's why we use a common term, high-grade AV block.
Yeah. What I understand, sir, as Jamil Bhai has said, in case of complete heart block, no P are conducted into ventricle.
Yeah.
The ventricular P goes on their own way. But in case of high-grade AV block, some of the P's are conducted. Most of them are not. But not in a fixed pattern. That's the problem.
Yes.
Absolutely. So, I mean, for the audience, that if it looks like complete heart block, but just like this case, we think that this is a conducted QRS complex, then we are calling it high-grade AV block. In clinical purpose, in all clinical purpose, this patient should be treated as complete heart block. Please remember, if this patient comes to the hospital without any symptom, we don't necessarily have to put a temporary pacemaker in. We don't do that here. If this patient came with syncope and there is no other reversible cause, we try to put the permanent pacemaker as quickly as possible. Adding a temporary pacemaker adds to the complication. Another procedure for the patient, it increases the risk of infection. So that's it. I think this is the last ECG. Thank you very much.
I like to add something. Today I did one dual chamber pacemaker in a lady, aged 50 years old. She was having this kind of high-grade AV block, and she had even pulmonary edema also. So she has no history of syncope, but she had features of pulmonary edema, and on exertion she is very tired. So I put her a permanent pacemaker today.
Yeah. So one of the thing about permanent pacemaker, so one of the thing that happens, this patient has left bundle branch block. And so when you put the ventricular lead, you have to be very, very careful if there is a temporary pacemaker. Because you go with the ventricular lead and you touch the right ventricle, right bundle, and you can develop a complete heart block. That means there will be no escape bit at all. And if that happens, what I do is I use that first lead active as a temporary. So I go with the lead quickly, anchor it, and then use the second lead for the ventricular pacing. And the first lead, if it is an active lead, I use it in the atrium. So that's the trick to use just to avoid temporary pacemaker. We rarely put temporary pacemaker before permanent pacemaker implantation. Thank you.
Thank you, sir. Thank you, Dr. Khalequzzaman, sir. I think we are at the end of our session. Now I can request, may I request Professor Atahar sir to show the ECG of the week.
Ribu, can you share your slide, please?
Yes, sir. I'm sharing, sir.
Dr. Kanis Fatima, have we answered your question?
Yes, sir. Thank you.
Thanks.
Thank you, sir.
There is one more concern about pacing in patients with hyperkalemia. It is difficult to pacing. but it does not pace with hypokalemia.
Ribu, show the ECG.
Yes.
Yes, sir.
Ribu, can you
Sir,
go for
I
the
should. Yes,
next
sure.
one? Yes, you are visible. Go for the next one. Next slide.
Yes, sir. Just 1 second, sir. Yes.
Sir, Ruby
Yes.
sir, this ECG was posted in the Facebook. Me and Abdul Chowdhury have seen it, and its answer was given by our Dr. Abdul Al Jamil. So we
Will
have
I
got
show
the
the
answer. But before that, we want to share the answer, and finally we want to have some comments from Rufik sir. Wadud bhai, the interpretation, please.
Yeah, remove the next
Here it
one.
is. Yes, sir. Here it is.
Wadud bhai, please, interpretation.
We see that general impression is there is a supraventricular rhythm, rapid rhythm, relatively narrow complex. Rate is 150 BPM, and we call it, there is SVT, then sinus again SVT, QRS is normal, hypertrophy is there, LVH criteria fulfilled. ST2F changes not there. Now look at the ECG. Go back to the ECG again. Reboot.
Yes.
Go
sir.
back to the ECG.
Yes, yes, sir. 1 second.
You have to be sharp. We will be going back and to the answer again.
Sir, the internet is very slow, sir. 1 second, sir. Yes, sir.
Now look at this. The initial part, narrow complex, rapid, no P wave. Then again, there is a pause, then there is a typical sinus rhythm. It's going on for 1, 2, 3 beats. Again, there starts a premature beat. Again, it starts a rapid rhythm. Now look at V1. The first one, PQRST. Second one, PQRST. Third one, PQRST. Fourth one, look at the second hump of the QRS complex. That hump, RSR prime like feature, is not present in the first 3 QRS complexes. And among these 3, the third QRS complex is early. Probably that has started this tachycardia. Now go back to the answer.
Yes, sir.
Atrial flutter is a possibility, but this
Narrow
this
complex.
narrow complex starts by a premature beat, and no P we have seen. Chowdhury in V1, as I have seen, the second hump we have seen. So most likely diagnosis is AVNRT. That's the answer provided by Dr. Abdul Al Jamil bhai.
In the first part of the ECG,
Go back to the ECG.
One can look at the first tachycardia, the last beat, that is the 8th beat of the first part. It looks little bit different than the other complexes, and also on timing. So it seems that this one was another ectopic beat which terminated the SVT. And again another beat in the second half, last half, what Dr. Wadud explained, then another ectopic beat again restarted the tachycardia.
Sir, কিছু বলবেন, Prof sir?
I have a little problem with AVNRT. How old is the patient?
Sir, 50.
50. So one of the things that look at in V1, there is a P wave here, right? And then there is a P wave here. And then QRS complex. And I was wondering that if this sharp point of the P wave is the P wave. And why am I thinking that way is because if you look at lead V6, this part, maybe it is a distortion, but over here, there is some distortion over here. So I am
Sir,
thinking,
you have to mention the beat name because we cannot see the cursor.
oh, So in lead V1, V1 and number, oh yeah, that's true. You cannot see my concept. So
Yeah.
lead V1, the first beat, second beat, third beat looks like the fourth beat on the T
Is
wave
different.
is different. So I am wondering, there is a possibility that this is an atrial tachycardia.
Yeah.
If it is not atrial tachycardia, then my problem is, how did it initiate? Who started the tachycardia? Is it the third beat or is it the fourth beat? If the fourth beat started the tachycardia, then it looks like an atrial tachycardia. There is no PR prolongation, or it's an atypical epinordial tachycardia. And now it is true that you can see this R prime in lead P1. But if we look at lead, these are not simultaneously. So, I mean, R prime, I know where you are getting it from, that R prime is making it the possibility. But I think if you look at lead P2, there is some change in the T wave, which probably is a P wave. So it is either atypical evinode reentry versus atrial tachycardia. I mean, if it were an older person, I would have thought of more of atrial tachycardia, but we have seen younger patients with atrial tachycardia. So, but, I mean, these are all differential diagnoses, evinode reentry plus atrial tachycardia, and then the EP study, of course, is necessary. I mean, please let me know, are you going to study this patient?
Yes, sir. He is in the list, but we have not yet studied, sir. We don't know the final diagnosis, sir.
Okay, so can you keep us posted? Once you do the study, can you bring this back and let me know what it is?
Sir, can I ask you a question?
Yeah.
Sir, can I ask you a question? Let's say this patient has COPD and she is 60 years old.
Yeah.
What will be the more possibility of atrial tachycardia, isn't it?
COPD, atrial tachycardia. I mean, it has to be severe COPD, and you see more multifocal atrial tachycardia than this kind of atrial tachycardia. So this tachycardia can happen in a regular basis. This is a very regular tachycardia, unlike that what we normally see with bad COPD patients.
Sir,
this patient has low voltage ECG, so there is a possibility of COPD.
Sir, actually, what confused us, sir, that in V1, actually, what seems to be the P wave, sir, in case of the V1. If this is the V1, this is strong point in favor of the atrial tachycardia. But, sir, look at the, sir, this V, that is the P, what is we call the P, that is in V1, that is coincides with the T in case of the V6.
Yes.
So this is the reason actually we did not think, yes sir, this is definitely can be a P wave, but we thought that sir, this could be the T wave. Because of the
yes, and no question about it. I mean, that's the problem part with this ECG. But if you look at the T wave of the second QRS in V1 and the T wave one before the last QRS, it looks as if it is distorted in a way, looking like a P wave.
Right, sir.
So that's the only problem.
And the thing is that the tachycardia rate is around 150.
Atrial flutter will not fit in. I'll tell you why. Because if it is atrial flutter, the second P wave, the timing may not be right, and it is not exactly, what is it, 150?
no, sir, it's
No.
a bit more.
A little bit more than 150, and there is a little warm up. There's a little warm up of the tachycardia because initially the RR is longer. The warm up actually supports
atrial
tachycardia
more than avinode reentry.
Sir, if you don't mind, can I say something, sir?
Yeah, sure.
Sir, if you look at V3, lead V3 or V4, sir, and since the second complex, the third one, ongoing the third one and continuing that, there is PR prolongation. which we find in 80. If we
Yes.
follow, sir, there are some PR prolongation.
Yes. So
Isn't it, sir?
yeah,
So
exactly.
which goes more in favor of 80.
Yeah. My first diagnosis is atrial tachycardia. Second is atypical evenodrine. But I will buy any other diagnosis. I mean, so this is, look at this. I'm talking to the audience now, younger participants, that here we are pretty senior physicians. We are discussing this, the options, possibilities, and that is what medicine is all about.
We have to treat it like a supraventricular tachycardia, but the underlying cause that has to be identified, and these are the cases that should be referred to EP specialists.
Okay, sir. I'll do the EP study and let you know the answer, sir.
Yes, but please remember one thing. If you do electrophysiology study and you find dual evinodal physiology but cannot induce SVT, I will not do ablation, because there is a possibility. Sometimes if people have recurrent SVT and we see dual evinodal physiology, even if we cannot induce SVT, sometimes we do evinode modification. But in this case, I will not do it unless I can prove that I have inducible evinodal reentrant tachycardia.
Thank you, sir. I think we are almost at the end of this session. Atahar sir, you have got some final comments.
Well, guys, really, this was a wonderful session, and we must congratulate Dr. Khalequzzaman.
Yes.
It was really memorable and wonderful lecture, particularly on these complex topics. And again, we must congratulate and welcome Dr. Hafizul Hassan. He's not in the screen possibly, but it was really a good experience, and we always want to share some experience with Dr. Hafizul Hassan. We want to ensure that he will be in our all lectures, sir. If he's got time, I request Rafiq Ahmed sir to actually say our invitation to Hafizul Hassan sir to, if it is possible, say, but we want that he will be in every lecture and like he will share the ECGs like you, sir.
Actually, Rafiq sir insisted that I invite him.
Yeah, Hafiz is a good academician.
Yes, sir. And finally, also Rafiq Ahmed sir, this was actually this is the glory and glamour of this session, that is Rafiq sir's session. And finally, all our other panelists, Dr. Zamil, Meshkat Ahmed Bhai, and possibly there are also our other faculties, senior faculties. I cannot see in the screen, but whoever in the present in the screen, actually we must congratulate everybody. And finally, it is a Beximco. We are actually giving us a tremendous support to make our program successful. Beximco, Rifu and Shubhro.
Thank you. All right.
Thank you.
Thank you,
Thank you,
sir.
sir.
Thank you, sir.
Thank you, everybody.
Next day, the next day, sir, the program will be the Saturday.
Sir, next day from Nepal, Arun will be presenting a case. I think he will follow up with some investigation. He's waiting for that. Arun, would you make a comment?
Yeah, I mean, last time we had a case, 71 years old gentleman. He was referred as a bradycardia. Heart rate was around 30, 34.
Arun, do not divulge too much. Keep the
that's right.
mystery.
Keep it a secret.
Yeah, he was past history of dizziness, but no syncope. So I'll send. Wadud bhai, can you send me Rafiq sir's WhatsApp?
Email.
So I'll send all those data so he can.
I will send.
Please send the email. It is better on the email, then I can easily modify those.
Oh, sure.
Thank
you.
Yeah, I will send it, sir.
Sir, our next program Saturday 8:30, and our
Atahar bhai, can we make it 9 from next month?
Okay, if everybody agrees, then sir, Ravi sir.
Yeah, I'm fine.
It is helpful for many of us.
Okay.
Ribu.
Yes. Thank you very much.
9 to 11.
Next lecture, Rafi sir, na?
Yes, sir. Yes.
All right.
Next lecture, Rafiq sir. White complex taker.
White complex taker.
Yes,
Right.
yes.
Yeah, sure. Okay. Thank you.
Thank you, sir.
Thank
Till
you, sir.
9 p.m. review. You please just let everybody know.
Okay, sir. Okay, sir. Noted, sir. I will change accordingly.
Assalamualaikum.
Thank you,
Thank you,
sir.
sir. Assalamualaikum.
Uh,